Hello, everyone. This is Sierra Hatfield, Policy Analyst at the Council of State Governments headquarters here in Lexington, Kentucky. I staff the Interventions to Save Lives Subcommittee of CSG's Healthy States National Task Force. One of the policy areas the subcommittee has identified is behavioral health access, with a special interest on substance use disorders, or SUDs, and how states should approach them as behavioral health issues that can be treated rather than as criminal acts to be punished. So I'm talking today with Debbie F. Plotnick, MSS, MLSP, who is the Vice President for State and Federal Advocacy at Mental Health America, or MHA. Recognized as a national thought leader on a wide range of topics in behavioral health, she provides leadership for grassroots and legislative advocacy across the MHA affiliate network and coordinates the Regional Policy Council, which focuses on state-level initiatives. Her most recent projects include working with the firearm industry to promote mental health screening and training in suicide prevention. Informing her perspective and her passion are her own lived experiences and her dedication to mental health systems advocacy. She is here to tell us why SUDs should be treated as behavioral health issues and offer up a few policy recommendations for our subcommittee members. So if that sounds good to you, Debbie, I'd like to start by asking, what does Mental Health America advocate for those struggling with SUDs?
Thank you, Sierra. It's my pleasure to be joining the Council of State Governments today on this really important subject, and I will tell you exactly what we believe by framing it within our policy perspective. Mental Health America, which, by the way, just celebrated its 111th birthday, really stands for four very simple things, and that is prevention for all, early intervention for those at risk, integrated care and treatment, and recovery as a goal. And that said, when it comes to mental health and substance use disorder, and it comes to transforming systems, Mental Health America believes that this kind of systems transformation will occur only when all stakeholders view recovery as the primary goal. And we define that broadly as a journey of healing and transformation that enables a person who has a mental health and I'll get more into that, a substance use condition, to live a meaningful life in the community of his or her choice while striving to achieve their full potential. Now, Mental Health America is greatly concerned, and one of our main policy perspectives is to change the fact that mental health conditions, and this includes substance use conditions, are the only conditions that we wait until, as we put it, stage 4 to treat, and then often only for incarceration. And not only is that the difficult policy perspectives for the individuals who end up in the criminal justice system, it is without a doubt the most expensive and inefficient way to assist people.
So you mentioned stage 4. What does that mean? Like, what are the other stages?
Well, really, I think most folks can right away run to what stage 4 means. When we hear that, we often think of cancer, and we think about the fact that it's spread everywhere. But at stage 1, it was small, it was contained, we could easily remove it, or better yet, we could we could do prevention, things like, if we're talking about cancer, not smoking or not, having exposure to things that might cause cancer, but people are at risk. A lot of folks are at risk for a lot of reasons, so we're going to check them early. We're going to do some screening. We're going to identify a problem. We're going to deal with it promptly. And when we're talking about mental health and we talk about stage 4, we're talking about folks who often end up cycling in and out of emergency departments, and worse yet, in and out of the criminal justice system. And by waiting to only pay attention to people when they are in that crisis, in that stage 4, we are doing a great disservice.
Okay, so when you and I had talked previously about kind of this interaction with SUDs and incarcerated populations, you had told me that incarceration can actually make the issue worse. Can you speak on that a little bit?
Absolutely. Incarceration is very traumatizing to people, no matter what. It's not a good place to be to end up in jail. It's hard on folks. But it's particularly difficult when someone has a mental health condition and a substance use condition to end up in a jail situation. Now, one of the things that I really want to start with before we get very, very deeply into that is the fact that we know through multiple national population surveys that about half of those people who experience some type of mental health condition through their sometime in their life also have a substance use condition, and vice versa. So we know that folks with mental health conditions often self-medicate with substances. They often then develop a substance use condition. We also know that folks who begin their journeys of incarceration and repeated cycles sometimes start with a substance use condition that arises out of the opioid crisis and the overprescribing and these types of things. But again, what will co-occur very likely will be extreme duress that will result in some type of other mental health condition, depression, anxiety, PTSD. We know that when folks get caught up in the criminal justice system and end up in the jails, very likely we're going to exacerbate the underlying conditions that brought them into the criminal justice system, either because their behavioral health issue is not being addressed and they were acting in some way that caused the criminal justice system to become involved, or the fact that we use police as first responders and that often results in folks being taken to jail instead of treatment, or we know that folks have a substance use condition that also lands them in jail, and then we've never paid attention to their underlying mental health condition. We know that often when folks with substance use condition end up in jail and there's not treatment for them, they can go through extreme withdrawal symptoms right then and there, which is very, very difficult. We know that when folks end up in the criminal justice system with a substance use condition that is not attended to by the criminal justice system, or when they come out, then they are very likely to die within a very short amount of time because the issues have not been addressed. So the overdose deaths that follow that, when these issues are not attended to, again, it is very, very difficult, and the mortality rates are very high, as well as the return to prison. The reincarceration rate is very, very high.
So what are some things, in your opinion, maybe that you've seen or heard of? What can states do to kind of stop these people with SUDs from only having the option of being incarcerated?
That's a great question, Sierra. And there's a lot of things that states can do. And that goes back to Mental Health America's perspective about we can do a lot to prevent. We can do a lot, and a lot of states are doing education that begins very early. Education in schools about mental health conditions and substance use conditions. We know that major mental health conditions almost always manifest in adolescence and at the latest by early adulthood. We know that kids themselves who are starting to feel something isn't right will often self-medicate with substances leading to that substance use condition. So awareness, education for students, for teachers, for screening is a huge step that states can take, and there's many ways they can do that. Some states that have some terrific bills right now around education. New York has a terrific bill. Minnesota has just passed a terrific bill. There are lots of states who have these kinds of bills, and many governors' budgets are including monies for education in schools, for treatment in schools, for telehealth in schools. For example, Ohio just put that in their budget. Tennessee has just also included a great deal of money in that same kinds of realms for helping. So there's that piece that states can do. I will also say, and this is a little bit controversial, but it is without a doubt what all of the evidence shows, that states can expand Medicaid for the population of folks who found themselves in the expansion population. About a third of them had untreated mental health and substance use disorder conditions. But by giving them some access to coverage and allowing them to get the types of treatment that they need, that makes a huge difference. Another thing that states can do when it comes to Medicaid and folks who find themselves already in the criminal justice system. We know according to federal law, Medicaid is not allowed to cover anything when a person is incarcerated. Many states have passed legislation that allows them to just suspend that Medicaid coverage that a person may have already had or that they might be eligible for. So making sure that that's turned back on and that people have access to treatment, to follow up, to care, to attend to their underlying mental health issue as well as their substance use condition, again, is a major step in preventing reincarceration. There are many other things that states can do, and states are doing a great job of. So we want to make sure that we're looking to as much prevention, screening, early intervention as we can. But we know that many folks will, not be caught as early as we like. So we really need to make sure that the states have the ability to divert people out of the criminal justice system, away from it. And there are many ways to do that. Some of the best known ways involve something like crisis intervention teams. And these are special teams where police officers who often get a first call about a mental health crisis or a substance use disorder crisis, to make sure that they have the training to understand that someone is having a mental health or substance use issue, and again, not take them to jail. We know that if folks are arrested, another piece can be courts that will divert them away. We know, I want to back up 1 minute. I forgot to mention that if we're having the police officers who are coming not take people to jail, many states and localities, counties have set up crisis diversion centers. And these are sometimes attached to hospitals, so if people don't have to go into emergency rooms, or freestanding, or in many other states, something that's extremely cost effective is to work with people with lived experience who are specially trained. They're known as certified peer specialists. And in many places, there are peer-run respite houses that police can divert people to. We know that in many places, mobile crisis teams are called, which are extraordinarily helpful. Again, instead of sending out a uniformed police officer, when peers, again, these specially trained people who have lived experience are part of the teams that are either riding with police or mobile crisis, what a difference in connection that can make straight away to help people and to divert them out of the systems. If they're ending up in the systems, specialized mental health and substance use disorder courts can again be very helpful. But we find that there are lots of things we can do so we don't have to get there, but if we have to get there, there are very, very good models established for both substance use and mental health courts. And we know that it's essential that once someone is leaving a criminal justice situation, that they have connection and follow-up in the community to continue treatment, whether that treatment is for a mental health condition on its own, a substance use condition on its own, or more likely, the combination of the two.
Wow, that was a lot of information. I think that I just have one more kind of overall arching question. I think that you have provided already some really good examples of things that states are already doing, examples that states could take a little bit further, but I want to say this. So the subcommittee is very focused on kind of two research priorities as we talk about behavioral health access and our other topics. And those priorities are, number one, savings, but not just fiscally, that's also in terms of human lives. And then the second is the subcommittee wants to find recommendations for all ages. So with either one or both of those things in mind, what would you say directly to the subcommittee as we continue this conversation about why we should treat SUDs as behavioral health issues?
That's a wonderful question, Sierra, and it's really from a fiscal point of view, and I'm going to talk about fiscal because I know that really matters to states, but I know whether we approach it from the human capital perspective, such as keeping people in school, keeping them in the workforce, keeping them out of prisons, not expending police monies and so forth, we can just that all makes for people to have much better lives, not have criminal records, all of those very important human capital things. Let's talk about the fiscal piece. The Vera Institute for Criminal Justice estimates that an average, they've done the research, that the average cost per year to keep someone in a state prison is $31,000 a year. Now that's just the average. In some states, it's way more than that. It can be as high as like in 70,000. In some states, it's a little bit less. But overall, $31,000 a year. That's a huge expenditure. That is 100% on the states if they're ending up in those state prisons. But those aren't the only costs. We know that kids in school who, as I mentioned, will start manifesting some types of behavioral health issues quite early, and then they're acting out, they're behaving in ways that again involves the police or gets them expelled from school, and again they puts them on the road to what we refer to as the school to prison pipeline, not something we want anybody to end up in. So we know that that is a very expensive to school districts and to state education budgets. So we want to look at that. We know that it's very expensive for the criminal justice system to be using police officers, not to be doing community policing and the types of things that they're trained for, but to have them to be acting in many ways as if they are having to be that first responder. Now, they are first responders, but the only responder sometimes for mental health situations and acute crises. So again, that's very, very expensive to take officers and have to divert them in that way. So that is extraordinarily expensive. We know that people who have mental health conditions and substance use conditions often end up in emergency departments. And we know that emergency departments under federal law must treat everybody who walks through the door, but we're leaving a lot of uncompensated care there because folks who are doing that cycling, again, are very, very expensive. We know that there are some types of things that many municipalities are doing that in terms of outreach for folks who are on the streets that can save a lot of money. It costs a lot less to put together homeless outreach teams, and large numbers of people who find themselves on the streets have mental health and substance use conditions. And again, this is a chicken and egg kind of thing. If you end up on the street, you may have started out because of a mental health condition or a substance use condition, but it's so difficult to be there that you're going to end up with severe trauma, mental health issues, and often that substance use condition, because it's so hard to be out there and be clean and sober and and to deal with the trauma and the difficulty and the dangers of being on the street. So states and municipalities can fully fund outreach teams, again, that include peer specialists to connect with people, to offer them treatment and services, to bring them in and keep them out of that revolving door of involving the police, emergency departments, and the criminal justice system. So those are just some of those things to end that repeated cycle that costs so much for states. And most of this money does come out of the state budgets. So it's very important to be using every type of available asset that a state can by looking at proven methods, some of which we've already talked about, to make sure that there's screening for young folks, screening in emergency departments for substance use conditions, screening for suicidality. We know that when someone attempts to take their own life, and ends up in the emergency department, again, that's a very expensive cycle. And without having a continuum of care in the community, that really takes a lot out of state budgets, because so many folks have no coverage at all or no way to have a continuum of care. Another way that states can make sure that people do have that continuum of care, and this is not directly about substance use itself or about criminal justice, but it has a big impact, and that's making sure that states have a parity law. There's the federal parity law, which is just celebrated its 10th anniversary, that says insurance must cover mental health and substance use on par with other conditions. But many states don't, not the states themselves. Many insurance companies don't. Many people aren't getting it. So many states are putting some state laws to make sure parity is enforced that have some teeth in it. And that can really save a lot of money for state budgets, because if you make sure that people get the treatment they need before they end up in these outrageously expensive public systems like jails, like cycling in and out of the emergency department, then much money is saved and much suffering on the part of the individuals is saved. So parity is sometimes overlooked as a really important fiscal measure that will help the states hold their costs down.
So it sounds like if states would start viewing SUDs as more of behavioral health issues, it still costs money to implement these new initiatives, but it still costs way less than if they went through, like you said, a public system such as incarceration.
Absolutely, Sarah, and there's no question about it. And it's really not controversial about whether or not substance use disorders are mental health conditions. I mean, we just need to look at the federal agency, SAMHSA, the Substance Abuse and Mental Health Services Administration. We know that these issues are completely coupled. There's no evidence that they are not. Behavioral health issues may start by themselves and substance use comes in, or substance use conditions may be the first line and then resulting in substance use conditions actually change the way people's brains work. And, they again then can lead to a cycle of depression, of trauma, of all of these kinds of things that we've previously talked about.
So they go hand in hand.
Absolutely. And they cannot really be decoupled in any kind of way that makes sense, because they go so hand in hand. Beautifully put.
Okay. So I think those are all the questions that I have for you. If there's anything else you'd like to say to me or to the subcommittee as we push along in our research.
Absolutely. Thank you. And thank you again for inviting Mental Health America to participate. We have many things to offer for model bills in the states, and many ways that can cut state expenditures. Another way that states can cut their expenditures is by offering treatment within their jails so that people aren't coming back, because we know recidivism is a very expensive proposition. We know that many states already do offer, and many like Delaware, Michigan, Maryland, they're planning to offer medication-assisted treatment within their jails and prisons so that folks are able to come out and get back into life and get jobs and take care of their families and all the things that really matter to us as citizens, to us as family members, to us as community members, and certainly to the legislators as the keepers of the fiscal health of their communities.
Right, right. Debbie, again, thank you so much for being here. I'm so happy that Mental Health America has a place at this table. Thank you for not only your expertise, but in providing all of these great tangible examples already having in the states. I think that the subcommittee is really going to enjoy listening in.
Thank you so much, Sierra, and please feel free to reach out for any specifics in any other way that Mental Health America or I may be helpful. So again, thank you so much for this opportunity.